Good morning, everyone. Thanks so much for joining us for this learning activity that's part of the Knockout Opiate Abuse Day learning series. Knockout Opiate Abuse Day was held statewide as designated by Governor Murphy on October 6th, and throughout the month and really throughout the year, we're going to be continuing to provide learning opportunities for you to participate in. We're so pleased to have partnered with RIOT, the Rutgers Interdisciplinary Opiate Trainers Program, to provide today's training and learning activity to you. I'm going to turn it right over to Eric Muller and Dominic Vaughn from Rutgers University to kick us off. There are student leaders for the day. And Dominic, I'll turn it over to you for the first half.
Sounds good. Good morning, everyone. Thanks for joining us. Like she said, my name is Dominic. Eric and I are both from the Biomedical Sciences program. And if you have taken the time to fill out the survey, thank you for filling that out. And I guess we will begin. So for today's presentation, we will be addressing the opioid epidemic, a primer on opioid addiction, overdose, management, and medication-assisted treatment. And it is our hope that by the end of this presentation, you will learn a little bit more about the factors that led to the current US opioid crisis, knowing the proper uses of naloxone for overdose reversal, recognizing the signs of opioid use disorder, debunking commonly held myths and beliefs about treatment for opioid use disorders, and understanding the key role of medication-assisted treatment, which we'll go a little bit more about in detail later on. For the purposes of this presentation, we're going to explain some of the terminology. Opioid is the preferred term we will use, which refers to any opiate, whether prescription pills or heroin. We will explain receptors, agonists, antagonists, and partial agonists in more detail later in this presentation. And medication-assisted treatment is a pharmacologic treatment given to treat opioid use disorders. We will talk about how this works later. This is the main outline of the talk we'll go over today. There are four main areas, beginning with an overview of the opioid epidemic and how we got to where we are today. And what we find is that the opioid epidemic is really not a new problem. Opium, the substance obtained from the poppy plant, has been used recreationally and as a medicine since ancient times. This is before 3000 BC. The use of opium is mentioned in ancient medical texts. We find records of this in Assyrian, Egyptian, and Greek medical texts. For the United States, it was commonly dispensed in the 1800s by pharmacists and physicians for a range of problems until it was replaced by morphine. The first devices recognizable as hypodermic syringes were independently invented virtually simultaneously in 1853 by Scottish physician Alexander Wood and French surgeon Charles Gabriel Pravis. They were first used to inject morphine as a painkiller. Interestingly, Alexander Wood and his wife became addicted to injected morphine as a result of their experiments. In the middle of the 1900s, people continued to abuse opioids, cocaine, and amphetamines, but it went underground after the Harrison Act of 1914, which made it illegal to prescribe opioids for people with addiction. And then in the Great Depression and the two world wars, it severely restricted access. Then in the 1960s and 1970s, heroin use surged, promptly in part by Vietnam War soldiers who were exposed to it while fighting overseas. Unlike the doctor-driven previous drug epidemics, this one victimized poor inner-city neighborhoods the most. And then lastly, in the 1990s, the new emphasis of treating chronic pain and the widespread belief that these new medications had reduced the risk for addiction led to a rapid rise in use for the next 20 years. resulting in our most current opioid crisis. On average, over 130 Americans die daily from opioid overdose. And looking at opioid sales, deaths, and treatment, this trend, treatment admissions, this trend has only been on the rise since 1999. As sales increase, there's a corresponding rise in both the deaths and admissions attributed to opioids. However, of note, this is not a worldwide phenomenon. It's really more of a US problem, and to a lesser degree, Canada and Australia. In fact, the US, Canada, and Australia use 96% of the world's opioid analgesics, but make up only about 15% of the world's population. And just to emphasize, it was just those three countries that really make up the vast majority of opioid analgesics use. And New Jersey is really not an exemption to this. If you see on the graphic, each of those red dots represent death due to opioid overdoses. And New Jersey, although it's not number one in annual opioid overdose death rates, it's still pretty high up there. In fact, it's number 12 in the country. This rate of 22 deaths per 100,000 people is 50% higher than the national rate of 14.6 opioid overdose deaths per 100,000 people. And although New Jersey is only number 12, it still had the highest annual percentage increase in overdose deaths in the nation as of November 2017. From January 2017 to January 2018, annual counts of overdose deaths increased by a projected 21.1% compared to an overall national increase of 6.8%. And for the most part, in the beginning, New Jersey mostly mirrors the trend line for the United States. But in the most recent years, this has changed. New Jersey had the highest annual percentage increase in overdose deaths in the nation in 2017, with 5 times more overdose deaths than motor vehicle accident fatalities and firearm deaths. And for this first slide, it shows the early epidemic. It shows that the most heavily affected states for prescription opioids, as you can see, such as Florida and Kentucky and Tennessee and West Virginia, you can see that they're more darkly shaded and have a higher opioid prescription use. And this largely corresponds to a US map of unemployment. Again, we see that those darkest colors show the states and counties that are most heavily affected. For the most part, many of the states that were suffering from unemployment were also prescribing opioids more. And this brings us to the late or current epidemic. As of 2016, more Northeast states are now involved. They're really darkly shaded in that area. And like I said before, New Jersey is included in that. So how did this epidemic happen? This epidemic happened due to a variety of factors. One was an increased emphasis on treating patients' pain. It was even called the fifth vital sign, implying that it needs to be managed as aggressively as we manage someone's blood pressure. Another significant factor that contributed was the marketing of Oxycontin as non-addicting, when in fact it had significant potential to be addicting. Yet another factor was the influx of high-potency heroin from Mexico, this time targeting rural and suburban youth. There's also limited access to healthcare, which made it increasingly difficult for people to seek help and support, and vast unemployment as factories closed in recent years. And the issue of opioids and addiction stemmed from an old study back in 1980. This study was cited 900 plus times on Google Scholar and was probably the most convincing fact presented by marketers to doctors when selling them Oxycontin. In reality, this was just a letter to the editor where the author looked through hospital records of hospitalized patients given opioids for pain. This included a very limited population and can't be broadly applied, but marketers skew this information and the risk was underestimated. This letter of the editor, however, sparked a pain revolution, leading to vast overprescription of opioids, including the development of pill mills. In reality, the risk of addiction with prescription opioid use is higher than 1%. It's more like 10 to 20%, which is much higher than what the study cited. And oxycodone and oxycodone CR, or controlled release, are two opioids you may have heard of before. Oxycodone has a shorter duration of action and an immediate release given for acute pain. Oxycontin is an extended release formulation of oxycodone with significant abuse potential. This is because it can be crushed, sniffed, and injected, leading to a powerful high lasting more than 8 hours. Even though Purdue Pharma aggressively marketed this long-acting extended release formulation as resistant to addiction, we know that this is not the case. And again, as one can crush, sniff, or inject Oxycontin, the euphoria of this is as powerful as that of heroin. This can lead to a very powerful high that can last over 8 hours. And Purdue was largely successful in their campaign for marketing them. In the 1990s, Purdue aggressively marketed the use of Oxycontin to primary care doctors for non-cancer pain, things like backaches and headaches. And during this time, we observed a sharp increase in opioid usage, and these observations can be validated by looking at the number of dollars spent on opioids, over $1 billion in sales within 5 years of FDA approval. And Purdue is now involved in many lawsuits for their role in fueling the crisis. And we just wanted to gauge some of your guys' thoughts in the audience. What is the most common way that individuals who abuse prescription opioids obtain them? And if you want, you can just list that in the chat box there. So I see doctors and their primary care providers. Yep, primary care providers, friends or family, doctor shopping, primary care providers, family members, physicians. And you guys hit it on the mark for the most part. As you can see from the pie chart, over 50% actually do receive it from people that they know, a friend or a relative, for free. And that next biggest chunk is coming from a doctor. Recent federal data indicate that over 50% of those who abuse prescription medications obtain them for free from friends or relatives. This reality points to the need for education and outreach targeting families and friends that highlights the importance of not sharing medications and proper medication storage and disposal strategies. And from this graphic, we can see that the crisis is now characterized by 3 waves. The first wave was for prescription opioids. In the beginning, as doctors recognized this program and prescribed less, heroin rose after 2010. Once people couldn't use the drugs from their opioid prescription, they turned to recreational use, heroin, as a way to replace that. And now we are experiencing wave 3 since 2013, which is characterized mainly by synthetic opioids, such as fentanyl. More than 700,000 people have died from a drug overdose between 1999 and 2017, of which 400,000 involved opioids. Of the more than 70,200 drug overdose deaths in 2017, about 68% of them involved an opioid, 6 times higher than in 1999. And the sharpest increase occurred among deaths related to fentanyl and fentanyl analogs or synthetic opioids, with nearly 30,000 overdose deaths. And this graphic shows why fentanyl is so dangerous. As you can see in the photo, a lethal dose of carfentanil, so the bottle on the right, which just has 1 granule, is significantly smaller than a lethal dose of fentanyl. Fentanyl is significantly 100 times more potent than heroin. Only a few granules are needed for overdose. And carfentanil is 100 times more lethal than fentanyl. Oftentimes, heroin, it may be laced with fentanyl and has significantly contributed to recent heroin overdoses. And when we look at admissions for those using heroin, it has largely affected the demographic of young white males. This chart shows that prescription opioid misuse has affected whites ages 20 to 34 more than any other population subgroup. The opioid crisis continues to disproportionately affect non-Hispanic whites. And for the most part, among females, it shows the same trend. And heroin usage contributes to a large number of admissions. And moving on to non-heroin opioid admissions, the male-female gap reduces. The largest increase in chronic non-medical use of opioid pain relievers is among people aged 26 to 34 and 35 to 49. The second main area we will discuss is the disease aspect of opioid use disorder. It's important to recognize substance use disorders not as moral failures or weaknesses, but as a disease similar to other chronic diseases like diabetes and hypertension. And when we look at substance use disorders, we should look at them the same way we look at chronic medical conditions. As we can see, there are some key similarities between substance use disorders and other chronic conditions: genetic susceptibility, chronic pathophysiological functional changes, risk factors influenced by choices, similar treatment goals and strategies, and similar clinical outcomes. Opioids and other drugs such as alcohol and cocaine activate similar reward systems. Addictive drugs activate the reward system by increasing dopamine neurotransmission. While each drug has a different mechanism of action, each drug increases the activity of the reward pathway by increasing dopamine transmission. Because of the way our brains are designed, and because these drugs activate this particular brain pathway for reward, they have the ability to be abused. Thus, addiction is truly a disease of the brain. As scientists learn more about this disease, they may help to find an effective treatment strategy for the recovering addict. 10 to 20% of opioid users are at risk. Notice that it's not 1% like originally cited from that older study, but it's also not 100%. That said, the risk of addiction is significantly higher if they also have co-occurring psychiatric disorders like depression or ADHD, a family history of substance use or prior substance use disorder. Risk is greater in men than women and Native Americans. Prescription pain medication users are at risk of developing an opioid use disorder. People who are exposed to trauma are also at a higher risk. And this is the criteria for substance use disorder. The DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders, is the book used in psychiatry and behavioral health. It has a laundry list of criteria to diagnose a person with a substance use disorder. All of these can be roughly grouped into 3 types of symptoms. Those that have to do with a loss of control, physiological symptoms, and consequences of use. And substance use disorder is defined by having 2 or more of these symptoms in the past year. It's also important to understand that tolerance and withdrawal alone, as seen as the physiological consequences, as with caffeine, for instance, doesn't necessarily imply a disorder. On the other hand, if a person has two or more of these symptoms, tolerance or withdrawal aren't necessary for a diagnosis. So why do people use or seek drugs? This graphic helps explain their motivation for using them. It's a current theory described by neuroscientist and expert George Koob. He has helped us understand that in early substance use, people use it in order to get a high and feel good or achieve a positive reward, also known as positive reinforcement. However, later in addiction, most use is not really for the reward of getting high, but to take away bad feelings, such as withdrawal and depression. This is also known as negative reinforcement. And we see that in the graphic. So basically, in the beginning, people use drugs because it feels good, and later on, they take it to avoid those bad feelings. And for the second half of the presentation, I will hand off to Eric.
Thank you, Dominic. So what Dominic's gone over so far today has been the multifaceted reasons how we ended up here in the midst of the opioid epidemic, and a bit about viewing opioid use disorder not as a moral failing, but as a disease, and the reasons behind that. I'll be covering overdose management, and we'll be also discussing more about medication-assisted treatment and the many benefits of that. So listed right here are some symptoms of opioid intoxication and overdose. So for opioid intoxication, you could see that you're going to have the classic euphoria, but then physiologically, you're also going to have constricted pupils, slowed breathing, lower body temperature, your GI system, your stomach is going to become upset, and you might experience vomiting and constipation and drowsiness. And then overdose, you see people becoming non-responsive, pinpoint pupils, instead of slowed breathing, you see no respiration, lowered blood pressure, slow heartbeat, coma. The person may become cyanotic due to not breathing, and their muscles will become flaccid. Looking at these, you can see it's really an analogy that almost all of your body systems close down. Opioid overdose is a more extreme version of the intoxication, characterized by a more extreme version of those symptoms. The cause of death in opioid overdoses is the lack of respiration. Instead of going from slowed breathing to simply stopping breathing, and this is a direct effect of the opioid. So the cause of death for opioid overdose, as we said before, is respiratory depression. For every fatal overdose, there are normally 7 non-fatal overdoses, so not every dose is lethal. But the risk factors for overdose include using a higher dose or taking opioids with sedatives, such as benzodiazepines or alcohol. And this is true even for those who are using prescription pain medicines. And then some of the other risk factors are having additional medical diseases, such as HIV and liver disease, using opioids as an injection user, depression, and then if people in your household possess opioids as well. For overdose reversal, one way to manage an overdose is by using naloxone, also commercially known as Narcan, which is an opioid antagonist. We'll get a bit more into agonists, partial agonists, and antagonists later. But Narcan, an opioid antagonist, can reverse the process. It acts instantly, but its effects only last for 30 minutes. So for that reason, it's important to always call 911 and initiate rescue breathing before administering Narcan. You should always call 911 no matter what. Narcan's given intranasally. In the past, I worked as an EMT, and I've seen myself that Narcan, while an amazing drug that has saved many lives, it's still always important to call 911 because effects don't always last long. Someone may require multiple doses. Naloxone Access has improved greatly in New Jersey through free distribution programs, and it's also available at pharmacies now with and without prescriptions. It's available to first responders and even lay people who are willing to undergo Narcan training to give 2 intranasal doses. Rutgers conducts free Narcan training and distributes kits, for which if you're interested, you could contact Trish Dooley for more information. Her contact information is listed there. dooleypc@rwjms.rutgers.edu. I attended one of the trainings. They're short, but they're excellent. You get a lot of great information, and you definitely really get trained and feel comfortable afterwards. And then there's many other programs that New Jersey has been supporting access to giving more Narcan throughout the state of New Jersey. Generally speaking, opioid withdrawal is not a life-threatening condition, despite how awful of an experience it can be. It can be very uncomfortable for the person that's undergoing it. That person might experience anxiety, yawning, sweating, tearing, having a constantly runny nose. Their pupils may dilate very wide. They may have kind of that goosebumps feeling or muscle twitching. They again maybe have an upset stomach where they're nauseous and vomiting, or instead of constipation, which we saw with the symptoms of opioid intoxication, you might see diarrhea and abdominal cramps. They might experience some extreme muscle and bone pain. Again, generally though not life-threatening. So we discussed briefly about overdose management. Now we're going to go towards medication-assisted treatment. So recovery is biopsychosocial and spiritual, as addiction can affect many domains of a person's life. So treatment is need to be comprehensive to include all of these different domains, and that's going to give people the greatest chance at success in recovery. So biologically, you can use something to help with the withdrawal symptoms and the craving and any other medical conditions they might have. Psychological, it helps if you're able to also help treat any depression, trauma, or use of opioids as a coping mechanism. Socially, it's good to be in a good environment with supportive friends and family. Spiritually, it could help to have a sense of hope and purpose and altruism and forgiveness, and this could help aid in recovery. There are various methods of treatment. However, many are not going to be effective, unfortunately, in the long run. Remember, as discussed before, opioid use disorder is really a chronic medical condition. So detox is typically defined as 3 to 5 days as a brief detox to rid the body of the drug. If used alone, it's often ineffective with a 95% relapse rate. The 3 recovery support and 12-step and counseling treatment in CBT, slightly more effective. However, again, something we discussed just before is that we want to target this from many different aspects. So 3 FDA-approved medication-assisted treatment, or MAT, such as buprenorphine, methadone, and buprenorphine, which is Suboxone, methadone, and extended-release naltrexone, also known as Vivitrol, are 3 FDA-approved treatments that are available to us right now, and we'll discuss slightly later. So the rationale for MAT, or medication-assisted treatment, because it's associated with very following positive outcomes, not just detoxification, but maintenance as well. It helps prevent or lessen withdrawal and reduce use. So it's more likely to see negative urine drug screens on following subsequent visits. Patients who use medication-assisted treatment are more substance-free for more days and weeks. It's also been shown to reduce crime, infection, and rates of HIV. And finally, as you can see at the bottom, much greater treatment retention and fewer dropouts and reduced rate of death. Those are where your best outcomes for medication-assisted treatment are. As we mentioned before, opioid use disorder is a chronic disease, so you're going to have a variable course over 42 months. This is supported by a study that showed us that among those with opioid use disorder, 15% were never abstinent, 11% were always abstinent, 74%, majority reported using opioids intermittently. Ultimately, most with opioid use disorder have an alternating pattern of abstinence and use. However, it's been shown in multiple studies that medication-assisted treatment increases treatment retention. One study showed that of 20 people, 1 year retention rate in treatment was 75% of those in the buprenorphine group and 0% in the placebo group. So massive difference right there. Another study of patients in the primary care setting found that those on buprenorphine, more than 50% remained in treatment after 1 year. Here, this green line shows the percentage of individuals still in treatment who had been abstinent from illicit opioids for the past month, which continued to increase over the year of follow-up. So that's a lot of different talk about studies and the science behind it, but the key point really is that medication-assisted treatment is going to promote retention, and those who remain in treatment are more likely to, over time, to abstain from other opioids. Now, not only is medication-assisted treatment effective, but it also saves lives. Fortunately, patients out of treatment died at about 6 times the rate of people in the general population. However, while those in medication-assisted treatment with methadone brought this less than 2 times. Retention in methadone and buprenorphine treatment is associated with substantial reductions in the risk for all-cause and overdose mortality in people that are dependent on opioids. So we just discussed how great that we've seen medication-assisted treatment to be. However, there are some barriers to MAT access. Despite the ineffectiveness of detox alone, and despite advances in medical care and all the research supporting, there's still some significant stigma associated with being on maintenance treatment. So those are some of the personal barriers. There's also provider level where some providers still don't understand or really believe in medication-assisted treatment. And then there's more systems level. Again, more stigma and belief, misinformation and the beliefs that are previously held, and a lack of or limited insurance coverage for these medications. However, medications combined with psychosocial treatment tend to have the highest success rate, but there's still a greater need than we have access to right now. So opioids act in the body and the brain by binding to our receptors, so our mu receptors. There's agonists, which bind to the receptors and cause their full effect. Some examples of these are morphine and oxycodone. There's antagonists, such as discussed before, naloxone and naltrexone, where you have an agonist that's binded, and then your antagonist comes and displaces that agonist, and therefore it will lead to no effects. They have a greater affinity for the receptors than agonists, so they can displace them. And this is really how overdose reversal works. And then finally, you have your partial agonists, which have some of the effects of opioids, but not the full effect at the receptors. For example, you might get some pain relief, but you won't get that euphoria, that high that comes with them. An example of a partial agonist is buprenorphine. The affinity is the strength at which a drug is going to bind on and act on its receptor. The full agonist is the opioid itself. So morphine, heroin, oxycodone, methadone, those are your full agonists, which produce almost an unlimited effect. That's that green trend line there. And the more opioids you give people, the more they're going to be affected. This means people can overdose on these full agonists, as we saw before. If you give someone an antagonist, the blue line here, you're going to see no opioid activity because it blocks the receptor and does not promote any opioid effects. Partial agonists, such as buprenorphine, have analgesia at a lower dose. However, there's a ceiling to that effect, and it's not going to produce a high. Buprenorphine has a stronger affinity for the receptor than most opioids. So if you take opioids and buprenorphine, the buprenorphine is going to stay in the receptor, and the opioids will have no effect. The agonists really bind to and activate the receptors. The antagonists bind to the receptors but do not activate them. Buprenorphine is a partial mu agonist. It's one of the FDA-approved MATs for substance use disorders, and there's a maximum effect it can exert. It's not going to cause a high. Its strong affinity for the receptor will displace the other opioids and eliminate the reward for opioid use. The Drug Addiction Treatment Act of 2000 gave physicians trained in buprenorphine the ability to prescribe it in an office setting, a measure that's helping reduce some of the systematic barriers to MIAT. This is in part due to its safety profile of buprenorphine. It's low risk for overdose and lower potential for abuse compared to other opioids. Allowing doctors to do office-based prescribing of buprenorphine greatly increases access for opioid use disorder treatment, since in the past, the only option was methadone programs. The development of buprenorphine was very innovative in new treatment for opioid use disorders because it would not cause overdose and has a much reduced abuse potential than other opioids. There's an additional characteristic in the most commonly used preparation, which is called Suboxone. You can see a picture at the bottom left that adds additional safety and reduced drug diversion. So this preparation of buprenorphine is in a combination with naloxone. As we discussed before, naloxone is an opioid antagonist. So if you take the Suboxone that's directed sublingually, the naloxone is not going to have any effect, and it will mostly cause the person, and it will not be absorbed into the body really. However, if someone tries to crush or snort the buprenorphine tablet, or if they try to dissolve the strip to try to get high, in that case, the naloxone does take effect and can cause the person to immediately go into withdrawal and prevent any high. It's for this reason that the recommended preparation with naloxone, again called Suboxone, is used preferentially over the pure buprenorphine formulation, which is called Subtex, which has a higher street value and has some more abuse potential. Methadone is another FDA-approved medication-assisted treatment and is a full opioid receptor agonist. It's prescribed only in licensed methadone treatment facilities. We have many decades of experience working with methadone, but one of its main limitations is that it has complex medical interactions with other medications and lasts a very long time in the body, so that these complicated medication interactions are going to be happening for a while. But there is decades of evidence that support its use. It reduces and eliminates the use of opioids and cocaine, reduces risk of HIV, needle sharing and needle use, and reduces crime and incarceration. It's used for opioid use disorder only in licensed methadone treatment facilities. Methadone helps remove the cycles of intoxication and withdrawal because, unlike heroin and other opioids, it's very long acting. So you can see at the top with using heroin, you have these cycles that occur, but you have a functional state with methadone where there's not these repeated cycles. Taking methadone, which is long acting, prevents someone from going into withdrawal and experiencing withdrawal, as discussed before by Dominic, experiencing those negative reinforcers are ultimately drive people to seek and use drugs. In addition, methadone doesn't produce the highs of heroin with a rapid increase in blood level and sense of euphoria. Most people that take methadone say it makes them feel normal and not high. Yet another FDA-approved MAT is Vivitrol, also known as extended-release naltrexone. It's given as a shot every 4 weeks. You cannot begin until you're 7 days opioid-free. It's effective in that it's going to reduce your cravings, increase abstinence, and have greater treatment retention. But unfortunately, it does have side effects such as insomnia. The injection site where you get it, you can have reactions there. It causes nausea and headache. And unfortunately, it's very expensive at about $1,500 per shot. So for opioid antagonists, again, as we discussed before, affinity is the strength with which a drug binds to and acts on its receptor. Both naloxone and Narcan, or Narcan and naltrexone, they're both full antagonists, which displace the opioid from the receptor. They're different blockers, but work in a similar way. Naloxone is not orally absorbed, and it's really not meant for long-term medication-assisted treatment. It's meant for overdose reversal. Naltrexone works orally as well, and it can be used for alcohol and opioid relapse prevention. However, it requires a highly motivated patient who's fully abstinent of opioids. Otherwise, it kind of precipitates withdrawal. So again, they're both opiate antagonists, but naloxone Narcan is not to be used for long-term medication-assisted treatment. It's used for overdose reversal. So we discussed 3 options so far in our, for our medication-assisted treatment. We discussed buprenorphine naloxone, also known as Suboxone, Methadone, and extended-release naltrexone, or Vivitrol. All work about the same for abstinence, craving, and treatment retention. Methadone has been shown to be slightly better, slightly more effective for the more severe cases. This could be because the program that you would be attending requires frequent or daily monitoring. But at the end of the day, there's no one-size-fits-all treatment, but all are effective. So there are multiple options, and sometimes you might have to try to figure out which one would work best for someone who has opioid use disorder. So there are benefits from longer medication-assisted treatment is that you also see stabilization in 1 to 2 months and maintenance from months to years. Many patients only want to be on medication to detox, but the longer use of medication-assisted treatment is associated with much better outcomes. One study showed that at 3 months of follow-up, 88% of patients relapse into opioid use if medication-assisted treatment is tapered in the first month. So, again, it just shows how important it is to stay using the medication-assisted treatment. You have much better outcomes. Otherwise, if medication-assisted treatment is tapered too early in the first month, there's an 88% relapse rate. If somebody receives medication-assisted treatment for a 2-week detox and then it's discontinued, there's going to be a very, very high relapse rate over the following 12-week period. You can see in this graph here that we have the maintenance condition where people continue with medication-assisted treatment versus the blue line where medication-assisted treatment was tapered very quickly. And you could see how long or how low the treatment retention went and how quickly. So again, detox alone is less efficacious than continued medication and maintenance treatment. We know medication-assisted treatment is working if the patient stops using other opioids, experiences no craving for the opioids, has no withdrawal symptoms, doesn't have side effects from the medications, and feels like their life is more stable, feels like their life is no longer out of control, and that they have are able to continue on a normal basis. Some people criticize medication-assisted treatment as continuing someone's substance use disorder, but we don't believe that to be valid. If someone is using substances, their life is often not in control right now with uncontrolled use and consequences. On medication-assisted treatment, their life is better and more stable with fewer consequences. The prescription monitoring program is a statewide database of patients with prescriptions for controlled substances, such as prescription painkillers. This helps halt the abuse and diversion of prescription drugs, includes pharmacy and out-of-hospital medications, has access to prescribers and pharmacists, and seen by law enforcement and licensing boards. The data is shared between states, but does not infringe on prescribing. There's mandatory enrollment for doctors in New Jersey. So this really helps prescribers have more information and help address the problem of prescription medication abuse. Not all medications are addicting. Ones that have special protection are scheduled by the DEA if they are addicting medications. And these drugs are scheduled 1 through 5 based on a combination of abuse potential and medical use. So a Schedule 1 drug has high potential for abuse and minimal medical use, such as heroin, right? And these drugs are federally illegal. Schedule 2 drugs have high potential for abuse, but also have a medical use. So methadone, you can see Ritalin there as well, hydrocodone, oxycodone. These drugs are legal, but we make sure to tightly control both their prescription and distribution. So we want to thank you for participating in our project and coming to the presentation today. The conclusions that we really want to take you away from this is there are several factors which led to overprescribing, such as overprescribing, which led to the U.S. opioid crisis. It's not just one factor, it's multifaceted. So we strongly believe that substance use disorders are chronic brain diseases that warrant recognition and treatment instead of stigma, and that medication-assisted treatments are both effective but unfortunately currently underutilized. So we hope that leaving this presentation you feel more positive about medication-assisted treatment. And finally, before I turn it over back to Matt, we ask that you complete our post-survey as well on RURiot.org so we can make sure that we were effective speakers today, and to ask you to check out additional resources on www.ruriot.org.
Great. Eric, thank you so much. Dominic, you as well for a great presentation, and really just laying out so many of the components and aspects of this opioid crisis that we're all facing. It was a very informative presentation, and we're so happy to have you join us here today and appreciative. Just to introduce myself, I'm Matt Birchenow, the Director of Special and Virtual Events with the Partnership for Drug-Free New Jersey. And I want to thank everybody who was able to attend today. As Eric and Dominic both mentioned, please make sure you take this post-survey. I know it's very important to the work that RIOT is doing, and I know they would appreciate if you can make sure to fill that out. Before I go, I also want to thank Muzdalifa Syed, who did so much of the behind-the-scenes work in putting together today's webinar, but also with the RIOT program in general. I know she's doing so much there to make sure this important information is spread in communities throughout New Jersey. I'd also like to thank Dr. Jill Williams, Professor of Psychiatry and Director of the Division of Addiction Psychiatry at Rutgers School of Medicine. She's the supervisor of this program, and want to just thank her for her great work. As mentioned, if you visit the website, ruriot.org, you can find out how to bring this presentation to your community. I'm sure groups interested in learning more about this would be such a valuable resource, and we have a number of Rutgers students who are trained to bring that to you. So please visit the website and find all that information about how to reserve a time to have them make this presentation to you as well. So again, I want to thank all our presenters today and everyone involved in putting this together, and thank you for attending, and please make sure to finish the poll. Have a great rest of your day, and stay healthy and stay well. Thank you so much.